Irritable bowel syndrome Marie L. Borum, M.D., ed., M.Ph., M.A.C.P., F.A.C.G., A.G.A.F. Karen Chawla, M.D. Basics description: a gastrointestinal disorder characterized by chronic and/or recurrent abdominal pain or discomfort, bloating and distension, and alteration in bowel habits in the absence of an organic cause. May be characterized as diarrhea predominant or constipation predominant, may alternate between symptoms. Synonym: spastic colon, irritable colon. Epidemiology: irritable bowel syndrome, IBS, accounts for 30–50% of visits to gastroenterologists, second only to upper respiratory infection as cause of lost workdays. Prevalence: pooled estimate of 11%. IBS prevalence internationally ranges from South Asia, 7%, to South America, 21%. Prevalence in North America is 12%. Predominant age: 20 to 39 years. If age greater than 50 years, consider other diagnoses. In the United States, female male, 2:1, more common in low socioeconomic communities. Etiology and pathophysiology: the etiology is unknown, associated with abnormalities of intestinal motility and enhanced sensitivity to visceral stimuli. The trigger may be luminal or environmental. Evidence for the role of small intestinal bacterial overgrowth, SIBO, in IBS and association with antibiotic therapy is controversial. Older age and female gender are predictors of SIBO in IBS patients. The role of food sensitivity, genetic, and psychosocial causes are also under active investigation. 4 bowel patterns in the Rome-4 classification: IBS-D, diarrhea predominant; IBS-C, constipation predominant; IBS-M, mixed diarrhea and constipation; IBS-U, unclassified symptoms cannot be categorized into one of the 3 subtypes. The utility of subtyping has been questioned. Many patients change categories/subtypes over time. Genetics unknown. IBS tracks in some families. Twin studies do not, however, show a clear genetic component. Risk factors: other family members with similar gastrointestinal, GI, disorder. History of childhood sexual abuse. Sexual/domestic abuse, primarily in women. Depression. Gastrointestinal infection. Pediatric considerations. No risk to mother or fetus. General prevention. See diet. Commonly associated conditions: chronic migraine, fibromyalgia, chronic fatigue syndrome, sleep disorders, psychiatric disorders, major depression, anxiety, somatoform disorders, and post-traumatic stress. Chronic pelvic pain, temporomandibular joint dysfunction. Diagnosis. History. Rome-4 criteria: recurrent abdominal pain greater than 1 day/week, on average, in the previous 3 months with an onset greater than 6 months before diagnosis. Abdominal pain and at least 2 of the following: improvement or worsening of pain with defecation, change in frequency of stools, change in form, appearance, of stools. Patient has no warning signs. Red flags: age greater than 50 years, no previous colon cancer screening and presence of symptoms. Recent change in bowel habit, evidence of overt GI bleeding, melena or hematochezia, nocturnal pain or passage of stools. Unintentional weight loss. Family history of colorectal cancer or inflammatory bowel disease. Palpable abdominal mass or lymphadenopathy, evidence of iron deficiency. Anemia on blood testing. Positive fecal occult blood. Physical exam. Complete exam to exclude other causes. Vital signs and general exam are typically normal. There is typically an absence of jaundice and organomegaly, but there may be tenderness too. Palpation. Differential diagnosis: inflammatory bowel disease, lactose intolerance, fructose malabsorption, infections, Giardia lamblia, Entamoeba histolytica, Salmonella, Campylobacter, Yersinia, Clostridium difficile, celiac sprue, microscopic colitis. Laxative abuse, magnesium-containing antacids. Hypo/hyperthyroidism, pancreatic insufficiency, small bowel bacterial overgrowth, somatization, depression, villus adenoma, endocrine tumors, diabetes mellitus, radiation damage to colon or small bowel. Diagnostic tests and interpretation with a typical history and no warning signs: anemia or weight loss, only obtain baseline labs, complete blood count, CBC, basic metabolic profile, stool ova and parasites, fecal leukocytes, Giardia antigen, Clostridium difficile toxin, and begin treatment. Plasma anti-cytolethal distending toxin B, anti-CDTB, and antivinculin antibodies are elevated in IBS-D and IBS-M, but not IBS-C. 1. In patients who do not respond to treatment, further evaluation with imaging and/or endoscopy is warranted to exclude organic pathology. Initial tests, lab, imaging rule out pathology specific to the patient's symptoms, diarrhea predominant, erythrocyte sedimentation rate, CBC, tissue transglutaminase, rule out celiac disease, thyroid stimulating hormone, TSH, and stool for ova and parasites constipation predominant, CBC, TSH, electrolytes, calcium, screen for hyperparathyroidism. 2. Abdominal pain, liver function tests and amylase when obtained, abdominal computed tomography scan and ultrasound are generally normal. Consider hydrogen breath testing to exclude bacterial overgrowth. Consider small bowel series or video capsule endoscopy to rule out Crohn's disease, typically normal. SITS marker study may be used to evaluate colonic transit in patients with constipation. Follow-up tests and special considerations. Consider lactulose breath test to assess for small bowel bacterial overgrowth associated with IBS. Diagnostic procedures / other sigmoidoscopy / colonoscopy may be used to rule out inflammatory bowel disease or microscopic colitis. Alert screen all persons greater than 50 years of age, or those with warning signs / red flags, for colorectal cancer. Test interpretation non-treatment goals, relieve symptoms, improve quality of life. 2. Determine if diarrhea predominant, constipation predominant, or mixed type. Lifestyle modification exercising 3 to 5 times per week decreases severity. 2. Food diary to determine triggers. 2. Food found to be associated with IBS symptoms include vegetables, legumes, fruit, tea, and fiber-rich foods, which may increase intestinal peristalsis. Medications fiber supplementation, psyllium, increases stool bulk, does not typically relieve abdominal pain, may be used for all types. 2. B medications that improve abdominal pain, global symptoms, and symptom severity in all types. Antispasmodics such as hyoscyamine 0.125 to 0.250 mg po/SLQ4-HPRN and dicyclamine 20 to 40 mg po/bid can be used for all types but have adverse effects such as dry mouth, dizziness, and blurred vision. 2. Probiotics such as lactobacillus, bifidobacterium, and streptococcus. 3. C. Diarrhea predominant antidiarrheal such as loperamide 4 to 8 mg/day orally divided 1 to 3 times per day is needed to decrease stool frequency and increase stool consistency, does not help with abdominal pain, may also use diphenoxylate and atropine. 2. Bile acid sequestrants can be used for symptom control in patients with persistent symptoms despite use of antidiarrheals. These include cholestyramine, colestipol, and colsavilum. 4. Antibiotics such as 2-week course of rifaximin improve bloating, pain, and stool consistency. Allostrin, Latronex, 0.5 mg po/bid, for women with severe symptoms, associated with ischemic colitis, constipation, and death in a small number of patients on dansitron was found to reduce symptoms severity other than pain. 4. Iloxidolin, 75-100 mg bid, is a mixed opioid receptor agonist and antagonist that has recently been shown to relieve symptoms in diarrhea-predominant IBS. Adverse effects include nausea, constipation, abdominal pain, and pancreatitis. 4. Constipation-predominant laxatives such as polyethylene glycol may improve stool frequency but not pain. Antibiotics such as neomycin and selective chloride channel activators such as lubiprostone, amitiza, 8 mg bid can improve global symptoms and severity. 2. B. Linaclotide, guanylate cyclase 2C agonist, has been shown to improve bowel function and reduces abdominal pain and overall severity in adults only. 5. Placonitide, 36 mg QD, was recently approved by the FDA for use in patients with constipation predominant IBS, acts by increasing intestinal transit and fluid content. 5. Lobiprostone is also efficacious. It works by activating chloride channels in the GI tract to increase chloride-rich fluid content in stool and assist with bowel movements. 5. Mixed-use medications to match symptoms. 2. Treat underlying behavioral issues. Tricyclic antidepressants can help control IBS symptoms in moderate to severe cases. Behavioral therapy helps reduce symptoms. Issues for referral. Behavioral health referral may help with management of affective or personality disorders. Gastroenterology referral for difficult to control cases. Additional therapies. Probiotics use may result in reducing IBS symptoms and decreasing pain and flatulence. There is no difference among Lactobacillus, Streptococcus, Bifidobacterium, and combinations of probiotics. Ongoing care. Follow-up recommendations. Patient monitoring. The IBS severity scoring system is a validated measure to assess the severity of IBS symptoms and can help monitor response to treatment. IBS severity scoring system. How severe has your abdominal pain been over the last 10 days? On how many of the last 10 days did you have pain? How severe has your abdominal distension, bloating, swollen, or tight, been over the last 10 days? How satisfied have you been with your bowel habit, frequency, ease, etc., over the last 10 days? How much has your IBS been affecting/interfering with your life in general over the last 10 days? Diet. Low in fermentable oligosaccharides, disaccharides, and monosaccharides, and polyols, FODMAPs. FODMAPs are osmotic, so they may not be digested or absorbed well and could be fermented by bacteria in the intestinal tract when eaten in excess. A low FODMAP diet may help reduce symptoms. Increase fiber slowly to avoid excess intestinal gas production. Initially, consider 2 weeks of lactose-free diet to rule out lactose intolerance. Avoid large meals, fatty foods, and caffeine, which can exacerbate symptoms. Avoid foods that increase flatulence, including beans, onions, celery, carrots, raisins, bananas, apricots, prunes, Brussels sprouts, wheat germ, pretzels, and bagels. A gluten-free diet resolves symptoms for some patients, especially diarrhea predominant IBS, despite negative testing for celiac disease. Patient education. IBS is not a psychiatric illness, but is a chronic condition. No increased risk of malignancy prognosis. IBS is a disorder that reduces quality of life. Many patients have behavioral health issues. IBS does not increase mortality. 6. Expect recurrences, especially when under stress. Evidence suggests that symptom shifting occurs in some patients, whereby resolution of functional bowel symptoms is followed by the development of functional symptoms in another system. 6. References. 1. Rizai A. Park SC.